Okay, I'm going to keep my talk just like a skirt, short enough to be interesting but long enough to cover everything. So, okay, I want all of you to interact. Okay, you must have seen a lot of this in the morning. Can anyone tell me what this is? This was a, say, 1-year-old child with so and so. Leukocoria, very good. So what's your diagnosis? Or what's your differential diagnosis? Sorry? Retinoblastoma, very good. Now, you know the groupings of retinoblastoma? Are you aware of the groupings? The ICIOR grouping? Okay, basically there are 5 groups, A, B, C, D and E. And if the tumor belongs to group D or E, you as an ophthalmologist will very often try and do a enucleation. Okay, now when you do a enucleation, this is the eyeball that is sent to a pathologist. Can you make out the anterior and posterior aspects of the eyeball? Yes? So this is the optic nerve and that's the cornea. Now when we sample an eyeball, the first thing that we do is we sample the resected end of optic nerve because we want to know the spread of tumor along the optic nerve. Now depending on the location of the tumor, we take either a vertical, horizontal or oblique section. Now how do I as a pathologist know what part of the eyeball the tumor is? Is there any test that I can do? Yes, someone just said it. Can you be a little louder? You are right, whoever said it. Yes, transillumination. So you do a transillumination. Now this is how it is, you know how it is done. Now, can you see this dark shadow over here compared to this? So that's where the tumor is. So I sample the eyeball and this is how a retinoblastoma would look like from inside. Can you see this white fluffy cotton-like tumor? Okay, and then we also sample the peripheral calyx. Now retinoblastoma would look like this under the microscope. It has lots of viable blue and non-viable pink areas corresponding to necrosis. And then of course there will be foci of calcification which you otherwise see on a CT scan. Okay, now this is something very peculiar of retinoblastoma. Can you tell me what this is? Louder. Rosettes. What type of rosettes are these? Are these true rosettes or are these false or pseudo rosettes? Why are these pseudo rosettes? Yes, so you have a blood vessel at the center. And why do these pseudo rosettes appear in a retinoblastoma? Now retinoblastoma is a very rapidly growing tumor. So it tends to outgrow its blood supply. Hence tumor cells which are close to the blood vessel, they get preserved, while those that are away from the tumor, they tend to die out and get necrosed. Now these are how true rosettes would look like. So what are the true rosettes that we see in retinoblastoma? Ventosternal and flexaventosternal and homerite rosettes. Now how do you differentiate these two? Now in flexaventosternal rosettes, you have a central empty area which is seen, whereas in homerite, you get a central pinkish material which is called as neuropil. Fine. Now your pathologist tells you that it's a moderately differentiated retinoblastoma. What are you going to do next? What would you like to do? Are you going to send the child back home? Well, if I send out this report to Dr. Santosh or Dr. Vikas, they'll shoot me. The next thing that you're going to ask your pathologist is, were there any high-risk factors? So what are the high-risk factors? Extraocular extension, very good. uveal involvement. Anything else? Optic nerve involvement. Okay? So these are the high-risk factors. Involvement of the optic nerve, involvement of the resected end of optic nerve, involvement of the choroid, involvement of sclera, anterior chamber involvement, and extraocular tumor spread. Now based on the presence or absence of these features, you're going to decide whether you're going to finish with your treatment or you're going to give additional chemotherapy or you're going to give radiotherapy or whatever. Okay. Now, how many of you have ever seen an eyeball under the microscope? Okay, has anyone seen it? In books, pictures? Okay. So do you know where the lamina cribrosa is? Okay, can you make out this is the optic nerve? Okay, very good. Okay, now can you see this double blue band? What is it? What is a double blue band? That's the retina. Can you see the brownish line beyond it? No, that's the choroid. And then this is the sclera. So this is the optic nerve. Now how do I make out where the lamina cribrosa is? Now lamina cribrosa, suppose if you imaginarily join two ends of the sclera, and the line, part of the optic nerve which appears on that line is the lamina cribrosa. Okay. Now this is a tumor. That's the optic nerve. This is the head. That's the lamina cribrosa. So here the tumor is involving only the head, not the lamina cribrosa or the retrolaminar optic nerve. So this becomes a stage T2A tumor. However, over here the tumor is going through the lamina cribrosa into the retrolaminar optic nerve. So this makes it stage 3A. Now when your pathologist tells you that there is involvement of the retrolaminar optic nerve, you should always ask him how much. How long is the retrolaminar optic nerve involvement? Any involvement beyond 5 millimeters calls for intrathecal methotrexate treatment. Okay, now this is a section from the resected end of optic nerve. It's a transverse section, that's why you're seeing it round. All this blue thing that you see is a tumor. This makes it stage T4. Okay, now this is another resected end. Can you tell me if this is involved or not? Yes, the optic nerve sheath is involved. So that's a transmeningeal spread. This is again stage T4. Now this is the choroid. Here you see full thickness involvement of the choroid. Now when your pathologist tells you that the choroid is involved, ask him whether it is a focal involvement or it is what? Massive. Focal is anything less than 3 millimeters in any dimension. Anything 3 millimeters or greater than it becomes massive choroidal invasion. So massive choroidal invasion is a high risk factor. Focal choroidal invasion is not a high risk factor. Okay. What is this? What part of eye is this? Ciliary processes or ciliary body. Right. What is this? Iris. That's the cornea. This is the anterior chamber. So you see the tumor involving the anterior segment of the eye over here. That's again a high risk factor. Now this is a picture which shows sclera and full thickness choroidal invasion. Now here the tumor is budding into the sclera. And here you see tumor on both sides of the sclera. So that's extraocular tumor extension, which again makes it stage T4. Okay. Now this is another case. Does anyone want to describe this? What are you seeing over here? Quick. Neoplastic, non-neoplastic? No? What does the slit lamp show? Aren't you seeing infiltrates over here? Aren't there corneal infiltrates? What type of corneal infiltrates do you see? Anterior, posterior, full thickness? Okay, basically there are posterior corneal infiltrates in this picture. So a PK was done. Now this is how the section of the cornea looks like under the microscope. You have a band-like infiltrate in the posterior part. Now which are the clinical conditions where you see posterior corneal infiltrates? There are two important conditions. Which ones? One is microsporidiosis and second is viral keratitis or HSV keratitis. Okay. Now this is a high mag view which shows these blue bodies in the posterior part of the cornea. That's the GMS stain. What is the GMS stain? Very good. Gomery's. Why is it done? Fungus. But it also stains microsporidia. So if you see these black bodies, these are all microsporidia. And that's the smear which shows these refractile microsporidia attached to the epithelial cell. And this is the GMS stain again. This is the ZN stain, which can you see these magenta pink colored bodies? These are all microsporidia. So this is a case of microsporadial keratitis. Okay, now let's get on to the next one. What is this? Neoplastic, non-neoplastic? Non-neoplastic. Infective, non-infective? Non-infective. So what is it? Okay, so there are these, dot-like granular deposits over the cornea. Can you make out that? Okay. So what is it? Okay. Clinically, it was thought to be a granular corneal dystrophy. Okay. Now this is how the cornea in this case would look under the microscope. Can you see these acellular deposits under the epithelium? Now these, when you do a Mason's trichrome stain, they stain positive. So Mason's trichrome stain will stain granular dystrophy. Okay, now let's get on to this. What type of dystrophy is this? Very good, lattice corneal dystrophy. And what are the deposits you see in lattice corneal dystrophy? Amyloid. So what stain do you do? Very good, you do a Congo red stain. Can you see this apple green birefringence? That's very typical of amyloid. Okay, now what is this? Yes, you're right. Maculocorneal dystrophy. And what stain do you do? Alcian blue. Okay. When we do a Alcian blue staining, you get these blue colored deposits in the cornea. Okay. Now this was a middle-aged lady who presented with gradual diminution of vision over the past 3 months. Now this is the B scan. What does it show? What are you seeing in the B scan? Where is the mass? Is it a mass or no? Yes, okay. Where is the mass? Sorry? Yes, very good. It is in the choroid. So middle-aged lady with a choroidal mass, what is the commonest possibility? Choroidal melanoma, right. So you're going to do a enucleation if you're not going to do a plaque. So first you do a transdermal elimination. So I know where the tumor is. Can you see this black mushroom-shaped tumor? Can you or can you not? Yes. That's the retina and this is the tumor. Why does a melanoma grow in a mushroom-like shape? Any idea? Where does the melanoma come from, originate from? Yes, because of the Brooks. The tumor actually goes through the Brooks and once it gets into the vitreous, it kind of spreads. That's why it appears like a mushroom. Okay, that's the typical mushroom-like appearance that you see. Now this is how a melanoma would look like under the microscope. Can you see this mushroom-like tumor? Okay, let's get on to... Fine. Now this was a lady who had this kind of tumor in her eye. What is it? Is it a melanoma? Can it be a melanoma? Yes. What type of melanoma? Amelanotic melanoma. If it is not an amelanotic melanoma, what could it be? Any other tumor that you can get? Okay, metastasis. Something else? Okay, what is the location of the tumor? Okay. Yeah, this is a better picture. What's the location of the tumor? Is it near the optic disc? No. Is it scleral? No. Then where is it? Sorry? Very good. It's in the ciliary body. So what type of tumor comes in the ciliary body? What is ciliary body made up of? Histology, second year, MBBS. What is ciliary body made up of? What is it? Yes, muscles. What type of muscles? Skeletal or smooth? Smooth. So what is the tumor that comes from smooth muscles? Huh? Leiomyoma. So this was a leiomyoma. Okay. Let's get on to another one. Now this was a 33-year-old lady who presented with this mass on the lower eyelid. What do you think it is? 1, 2, 3, 4, 5. Any differential diagnosis? Commonest? Granuloma, pyogenic granuloma. Okay, anything else? More commoner? Chalazion? Yes or no? Okay, so what are you going to do? You think it's a chalazion. What would you want to do? You're going to excise it, or you're going to give intralesional steroids? What are you going to do? You're going to excise it. And then what are you going to do with that? Throw it in the dustbin? Okay, you got to send it to your pathologist. Okay, now when I saw this pinkish material which was present in the dermis. And I did a congruent stain, and it stained positive. And this was the apple green birefringence which I saw. So this was a case of cutaneous amyloidosis. Now amyloidosis per se is a systemic condition. So when you have a case of amyloidosis, always do a systemic evaluation. And this lady turned out to have bilateral ovarian amyloidosis. So these are the amyloid nodules which are seen in the ovary. That's the congruent staining, and this is the apple green birefringence which was seen. Okay, now this was a middle-aged man who presented with burning, watering, redness, seen about 1 month duration. What do you think about this? Neoplastic, non-neoplastic? Non-neoplastic. Infective, non-infective? Infective. So what are the possibilities? Bacterial, fungal, parasitic? Fungal. Okay. So what are you going to do? Scrapings. The scrapings did not show anything. What next? Yeah, you're going to do a corneal biopsy, or you're going to do a therapeutic PKA, right? Now this was the corneal sample. You see full thickness corneal infiltrates. That's the Descemet's membrane which is breached. You see infiltrates in the anterior chamber as well. This is a high mag. What cell is this? That's a multinucleate giant cell. It's kind of a foreign body reaction. Which are the conditions where you get multinucleate giant cells? Tuberculosis, sarcoidosis, fungal granuloma, and xanthogranuloma. What type of multinucleate giant cells do you get in a xanthogranuloma? Very good, Teuton giant cells. Okay. Now I did as a process, when we get a corneal sample, we do a gram stain, GMS stain, PAS stain, and ZN stain on all of them. So GMS stain showed these bodies. What are these? What do they look like? They look ball-like? Or to be more precise, do they look cyst-like? Now this was the calcofluor white stain on this sample. What is it? Acanthamoeba. Very good. Acanthamoebic keratitis. Okay, now this was a 5-year-old child who came with this rapidly growing eyelid mass of say 2 weeks duration. Now that's the CT scan which shows an orbital mass compressing the globe. What are you going to think of first? Rhabdomyosarcoma, okay. Anything else? Sorry? Leukemia, very good. So what is the first investigation that you would want to do on this patient? Peripheral smear, very good. So peripheral smear was done. This is what it was like. Hemoglobin was 10.2, total count fairly normal, 5,200. Platelet count was slightly lower, 1,11,000. Differential count was normal. Peripheral smear was reported outside as being within normal limits. Now what? What are you going to do next? Biopsy it. Very good. Okay, now it was biopsied and this is how it looked. What is it? The mass looked green in color. What's your diagnosis? This is a PG question, exam question. Chloroma. Why does it appear green? Sorry? What happens? The blasts in a chloroma, when exposed to sunlight, they emit a green color. And that's why it's called chloroma, because they are chlorophyll-like. Okay. So this was a case of a granulocytic sarcoma. Now, I give a diagnosis of granulocytic sarcoma. What are you going to do next? Yes? Bone marrow. Are you going to do aspiration or are you going to do a biopsy? You don't do an aspiration. Lymphomas, you do a biopsy. Leukemias, you do aspiration. So this is what the bone marrow aspiration looked like, lots of blast cells. And then there were some of these which contain these rod-like things. What are these? Or rods. So this was a case of AML. Okay, now this was a middle-aged gentleman who had this pigmented, can you see this ring-like pigmentation? What is it? Okay, now this was a slit lamp picture. Can you see anything over there? What is this OB scan? Is it normal or abnormal? Sorry? Just because I am showing it is abnormal? Or is it normal? It's normal. It's a normal OB scan. Yeah, I think this is a better picture. What is it? Posterior lenticonus. So what are the conditions which posterior lenticonus is associated with? Alport syndrome, very good. No. There are two more conditions. Spina bifida and Waardenburg syndrome. These are three conditions which are associated with posterior lenticonus. So what is the next thing that you do in a patient with posterior lenticonus? What examination or what test would you want to conduct? Simple procedure. You're going to do a urine examination because you want to look for microscopic hematuria that is seen in Alport syndrome. Okay, so these are the three conditions associated with lenticonus. Okay. I think we have time for one more case. Okay. Now this is another common condition which you come across in your oculoplasty clinic. An elderly lady with this nodulo-ulcerative eyelid mass. What is it? Sorry? Sebaceous carcinoma, yes. So what are you going to do with this patient? Simple. You're going to excise it, right? Okay. And what are you going to do when you excise it? You're going to have a margin control. You're going to do a frozen section for margin clearance. Now this is how sebaceous carcinoma looks like under the microscope. You have lots of these empty looking cells. Why do they appear empty? They contain lipid. And when we process it in our lab, the lipid gets dissolved in alcohol. That's why these cells appear empty. Okay. Now when we look at a case of sebaceous carcinoma, this is what we particularly look into. The spread of tumor into the epithelium. What is it called as? Have you heard of something called as a pagetoid spread? Yes or no? Which is the other tumor in the body which has pagetoid spread? Breast carcinoma, very good. So something similar to that, we have pagetoid spread over here. So always look for the report to see if there's a pagetoid spread. Now what should you look for in a report of sebaceous carcinoma? You should look for size of the tumor, you should look for tumor location, tumor grade, presence or absence of vascular invasion, status of the base, status of resected margins, and presence of pagetoid spread. Now pagetoid spread above the tumor is not prognostically important. It is pagetoid spread away from the tumor which is prognostically important. Now if I am your pathologist and I tell you that yes, this patient has a sebaceous carcinoma with pagetoid spread away from the tumor, what are you going to do next? Is there any other surgery that you would want to perform? Yes, you would like to do a map biopsy. And this is how map biopsy is done. You take tissues from different quadrants of the ocular surface, you put them on a filter paper. Dr. Santosh usually takes about 15 to 16. I think even Vikas does the same. And then each of them are studied separately, and then I say, whether it's positive or negative. Okay, fine. Now I tell you that the map biopsy is negative. What are you going to do next? Are you going to send the patient back home, or are you just going to complete your cutler beard? Is there any other investigation that you would want to perform? Okay. Can you tell me any syndrome that is associated with sebaceous carcinoma? We have 2 minutes left. One syndrome associated with sebaceous carcinoma. Mutor syndrome. So what is Mutor? It is a visceral malignancy associated with sebaceous gland lesions, most commonly sebaceous gland adenomas and hyperplasias, but carcinomas can also be associated. So in this lady, when a colonoscopic examination was performed, this is what we saw. There was a tumor in the colon. So which is the most commonest tumor associated in Mutor? It is HNPCC, hereditary non-polyposis colonic cancer. I think we are running out of time, so let's stop over here. Thank you.
Thank